Hello, hello. Happy Saturday, everybody. Welcome to another VMR. Yes, over the holiday break, we've incorporated a couple of additional VMRs because we're so lucky that the case review committee is thriving and has presenters from all across the world in all specialties. And today is very special because our case presenter is really somebody who's been part of VMR in many ways for quite some time, silently sitting there with often a very positive smile as he is right now. But before I pass the mic to our case presenter, I wanted to share my excitement to finally co-discussing with Kirtan. I think many of you probably are surprised by that, wondering, wait, how is that possible? Kirtan has been part of VMR for so long, but yet, this is the first time we're doing it, and I'm thrilled for that because I feel like we've literally been watching Kirtan shine and shine and thrive and thrive. And in fact, another VMR legend, Sammy Maddie, who was leader of VMR before he stepped away for his intern year, texted me yesterday commenting on Kirtan's presentation skills yesterday and how Sammy and many others, including myself, view Kirtan as somebody we all admire and strive to emulate, and has really leading the path in clinical reasoning in many ways. And so to share the stage with him is a delight. I'm really excited for it and really looking forward to it. Um, but I would also love to welcome Artem, who I've seen and interacted with on Twitter, and I see very frequently on VMR, and would just love to get to know you a little bit better, Artem, before you jump in. So tell us a little bit about yourself.
All right, good morning, everyone. My name is Artem. I'm currently a second year rheumatology fellow at Loma Linda University in California. So I'm originally from Russia. Kind of follow the same path as many of you here. Unfortunately, when I was applying, when I was going through all this journey, I don't think CPS existed. It was 2017, 2018. But really excited to see what you guys all doing. So many smart people all across the world. So it's really exciting for me to be presenting here today for you.
Well, the pleasure is all ours. I know Kirtan will be very curious. What prompted you to pursue rheumatology?
Just general curiosity, dissecting cases. I mean, this is all CPS is about, right? So,
100%. As and tell us a little bit about yourself outside of medicine. What do you enjoy doing?
I in residency I played soccer or football a lot. We actually had our own like little league,
Right.
which we established. It was called La Liga de Abington. Abington was my program. So right now I'm playing. I started playing tennis, so which I enjoy a lot too. Outdoor activities.
You like
All
out being
really
outdoors
fun.
and you like moving, huh?
Yeah, moving is living. Yeah.
I'm happy to share with you that that's the exact opposite of Kirtan. Kirtan, do you want to say hello?
Yeah, hi friends. And firstly, I wanted to thank Artem and Ravi for joining so early. I couldn't even imagine getting up and be ready at 6 o'clock. So thank you for that. And yeah, so as Ravi said that, I'm more of an indoor person. So like there is not a single activity which I did outdoor. In fact, when Ravi was kind enough to invite me to California and when I went there to meet him, that was probably the first time when I went outside and had a stroll with beautiful dog Nar, which Ravi has. Before that, I have never been outside in the park as well. So, like, thank you so much, Ravi, for bringing me out of my shell. And yeah, I'm so excited for today's case. And knowing the fact that Artem is a rheumatology fellow is a good start. So I already feel more comfortable, and hopefully things will go well. And thanks Anmol and Navpreet for helping with scribing and teaching points. Fingers crossed. Hopefully it will be a great discussion and we will learn a lot.
Absolutely, no doubt about that. Now, all of you can rest assured that while Kirtan teaches us about really cool diagnoses, we teach him about the beautiful outdoors, and it's in bi-directional, bi-directional learning. All righty, Artem, we're ready whenever you are.
All right. Let's start with the chief complaint. So I'm just gonna, all right. So this is a 65-year-old woman who presents with left eye vision loss, ptosis, and pain in her left eye, and her symptoms started 2 weeks prior to presentation.
Amazing. This
So
is yeah, the Artem's a really, really good start. Is it okay if we reflect here for a moment?
absolutely. So this is your
Awesome.
time.
Perfect. So, Kirtan, I think we heard three things that there's vision loss, there is pain, and there is ptosis. I'm curious, can you shed light in your mind on which, what order are you solving this? Where are you beginning and why? Are you choosing the vision loss, the pain, or the ptosis? What are you beginning with?
Sure. So I think in this case, I will be beginning with the vision loss, and then I will try to focus on the ptosis and pain as well. And whenever I am dealing with an ophthalmological problem, one approach which I take is the anatomical approach, so as to make sure that I don't miss any particular entity. So let's say if we start with the vision loss, then our question becomes that are we just talking about blurry vision, or are you talking about complete vision loss? So starting from the cornea, we can begin with if there is a corneal pathology like keratitis, then people can have some sort of blurry vision and photophobia. If we go beyond that, then comes the aqueous humor and the lens. People can have opacities in the lens, which could cause that. Then comes the vitreous humor. So in the vitreous humor, people can have hemorrhage. People can have subretinal detachment, which could cause hemorrhage, which can cause blurry vision. Then we come to retina. So in the retina, there can be so many things. People can have posterior choroiditis, people can have retinal vasculitis, retinal infiltrative disorders, and finally posterior to retina, we have the optic nerve itself. So optic neuropathy, optic neuritis can also contribute to the vision loss, and this is intraocular pathway. Then all the way back into the optic radiations and into the cortex that could define the vision loss. So first thing is to tease out where in this structure we are lying. Once we have figured that out, we can focus on ptosis and pain as well.
Yeah, that was a wonderful. I'm curious, if you could shed light on why you made that choice. So you chose the vision loss, and your approach to vision loss is anatomic, which is very helpful. But of all those things, what would be your rationale to explain to somebody why that was the decision to that you made?
So that's a difficult question, Rabi. I do agree, but I think the probably the reason why I chose that pathway was because there are so many options from which I can select, and once I can zoom in that pathology is in, let's say, retina or optic nerve, then I can do the Venn diagram and overlap that with ptosis and pain, and that would be easier. Now, pain is very non-specific. That's why I didn't want to go with the pain path.
Yeah.
Ptosis is a little bit specific, but the thing is that even if I figure out that ptosis is due to cranial nerve 3 palsy or not, I
Yeah,
still have a lot to explore in the terms of vision loss domain. That's why
I
went for it.
completely agree with you. I think that morbidity and diagnostic specificity are the two drivers that help us pick of which data to pursue. The hardest part about clinical reasoning is actually understanding what the core problem is and which data is given a heavyweight assignment and which data is let to drift away. And I think in a case where you have these three concerns, the morbidity lies in the vision loss, and the diagnostic specificity also lies in the vision loss, making the selection of this condition priority. Pain is non-specific, and ptosis can be fairly subjective, and a large fraction of patients with ptosis do not have any visceral complications. They have dehiscence of their aponeurosis, and while unlikely in this case because of the vision loss, if you just heard a 65-year-old man is coming in with ptosis, odds are that this person has had long-standing ptosis from aponeurosis dehiscence. So the diagnostic specificity is super low. I completely agree with you. So now that you've both outlined why vision loss and outlined your pathway for it, I'm curious, what do the ptosis and the pain help you in your ability to localize on that eye to brain pathway? Where do you think the lesion is based on the accompanying features?
Perfect. So I think with the pain part, I am worried more about could this be firstly scleritis? Could this be posterior uveitis? Or could this be optic neuritis? Now, what kind of pain are we dealing with will be helpful. Like pain with movement of the eyes will help you to localize to retrobulbar optic neuritis. But if it's pain just constantly present along with, let's say, lacrimation, then we would think more about scleritis. Same way, if patient has prominent photophobia component, then you will think about uveitis rather than optic neuritis. So accompanying features will help us, but I am focusing on sclera, posterior uvea, retina, and optic now. Regarding the ptosis, so ptosis drives us toward either the descending sympathetic pathway are affected, which kind of innervates the levator palpebrae, or is it the cranial nerve thought itself? Now, the reason why thinking about cranial nerve thought involvement is important is because in the posterior part of the orbit, whether we are dealing with orbital apex or the main orbit itself, there are so many nerves which are aggregated there before it spreads out, and so many orbital pathologies. So there could be, let's say, GPA is there, sarcoid is there, IgG4 are there. So many infiltrative disorders, either autoimmune, infectious, or neoplastic, can cause cranial nerve palsies. Now, as of now, we are just seeing ptosis, but when we will get to examination, who knows if patient also has abduction defect, adduction defect, so multiple cranial nerve palsies, which would further supplement our hypothesis that this is a process inside the orbit itself. And since it's in the orbit, it might be compressing on the globe, optic globe, and which can contribute to pain and ptosis as well. So that's why I am focusing more on the posterior aspects of the eye, probably optic nerve or the globe itself.
I'm right there with you, my friend. And I think it's amazing how much progress you can make. And I'll just spend 1 minute summarizing. You heard Kirtan outline his approach to vision loss, beginning at the cornea and ending in the occipital lobe, basically from eye to brain. And now we have to try to draw a cross section of where we can localize the lesion. Realizing that this is left-sided visual loss makes us consider nothing beyond the cornea all the way to the prechiasmic optic nerve. So already we can confidently eliminate most of the brain. So now we're from cornea to optic nerve. And now we can study the pain and the ptosis. And I would argue the ptosis has much more diagnostic specificity than the pain. And watch this. So what causes ptosis? Ptosis can be either a midbrain, paramedian midbrain issue, which is unlikely to cause vision loss. Ptosis can be a nerve issue, which can be either cranial nerve 3 or the sympathetic chain, and we'll come back to that. It can be a neuromuscular junction issue, which is unlikely to be associated with vision loss. Or it can be a muscle issue, which is unlikely to be associated with vision loss. So of the 4 possible localizations of ptosis, midbrain, unlikely to be associated with vision loss, neuromuscular junction, and muscle, the only overlap of ptosis and vision loss involves that of the nerves, either cranial nerve 3 or of the sympathetic chain. You may ask, is cranial nerve 3 palsy present here? And I would venture to guess that the answer is no. A very prominent feature of cranial nerve 3 palsy is the presence of diplopia or double vision as a result of ocular misalignment. It is possible to have a cranial nerve 3 palsy with ptosis as a partial cranial nerve 3, but if you're trying to make as much progress, vision loss plus ptosis often suggests disruption of the sympathetic pathway. And now you said we're vision loss we're already in the optic nerve and in the eye. Where does the sympathetic pathway align here? The sympathetic pathway goes through the cavernous sinus and into the eye through the same pathway that the optic nerve has, resulting in the conclusion that Kirtan made, that with these 3 words, you have to be careful to not lock in the localization based on this disease process, but this disease process is very evocative of orbital or periorbital, i.e. in the cavernous sinus, disease processes, by the simple overlap of vision loss and ptosis being so narrow that it really makes us wonder what's happening around the eye or right behind it, mandating that telling us that the exam of this eye is going to be profoundly helpful. And if it is surprisingly negative, it means that there is an inaccuracy in the HPI. Either the patient does have double vision and didn't realize it, or the patient didn't have ptosis and misrepresented it in some other way, shape, or form. But just watch how that combination is so specific to that area. Yeah, really, really well done, Kirtan. So we'll see what I just feel like we made Aaron proud a little bit by hearing the chief complaint and being very confident where the lesion is, but open to having more information that clarifies it further. All right, Artem, tell us more, please.
Right, these are all great points. So I think we started this dissection. So let's now move to HPI. So relevant HPI. So 7 months prior to this visit, the patient actually was diagnosed with a left cranial nerve 3 palsy. And this is all from outside records, which from outside records resolved. Then 5 months prior to this visit, the patient actually already had a complete vision loss of left eye with gradual recovery of vision to near baseline. Initially, we couldn't find any records, what was the reason for that. But then on further review, one of the records I found mentioned that there was a possibility of central retinal artery occlusion, CRAO. Then 2 weeks prior to this visit, this is when all this symptoms started. Again, vision loss, pain, especially with eye movements. This is what the patient mentioned. Review systems, I can also add here if you want, or if you want to reflect on that.
Let's maybe, Kirtan, I'm just curious what your reflex thoughts are with this additional data.
Yeah, so with additional data, it further helps us in localizing and making the progress. So in the first aliquot, we were discussing that how if the patient has pain with the movement of eyes, then we would think more about the optic nerve pathology or in the intraorbital pathology, because that's how the pain originates. So in this case, the fact that those things are present further supplements our hypothesis. Now, what could be the etiology of these conditions? Because now that we have localized, we have to start thinking that based on the time course, what are the diagnostic possibilities? So given the fact that patient is a lady, patient is above the 50 years of age, and patient had central retinal artery occlusion, one imperative diagnosis to consider is giant cell arteritis. And it would be interesting to see if 7 months ago, when the patient was diagnosed with all this condition, did she receive any steroid doses at all? And did it help even a little bit or not? Now, the reason why I am making a case for GCA is because often we think that GCA is a case of vasculitis affecting the optic nerve, and that's it. But the pathology runs deep. We know that all the cranial nerves themselves are supplied by the nerve vessels, because it's known as like vasa nervorum, which supplies the individual nerves. And all of these vessels eventually originate from ophthalmic artery, and which could be supplied by same pathology like giant cell arteritis. So people with GCA often present with cranial nerve palsies, although it's not the common symptoms that we are used to think about. So I would consider the GCA in diagnosis. Other possibility I would think is, could this be a pathology in the cavernous sinus, as Rabih was alluding to? So since it was painful, I am bound to think about one condition known as Tolosa-Hunt syndrome, which is like idiopathic granulomatous inflammation. Now, the reason why I'm saying that, because the time course. Now, in Tolosa-Hunt, often we have seen that people develop multiple deficits over the time course, like over months and months, as opposed to fulminant conditions, like let's say sarcoidosis, IgG4 or GPA, where it tends to happen in a same segment of the patient's life. So let's say in span of 1 or 2 months, as this is spaced out. So that is what made me wonder that what's going on. Now, one key thing which I wanted to mention here regarding examination was that if this patient has proptosis and if this patient has conjunctival erythema, then other thing to consider is carotid cavernous fistula. Now, carotid cavernous fistula is important to consider because just like the Tolosa Hunt, it can progress over years and years, and gradually that fistula worsens. So it keeps on applying pressure to all the structures in the orbit, and which will eventually cause multiple cranial nerve palsies. So these are the pathologies that I was thinking right now. And Rabih, I was wondering that, what do you think? How can we make further progress in this case?
It's incredible. I think your rich illness scripts allow you to engage specific diagnoses here. My mind is still not thinking of individual diagnoses right now. I'm just intrigued because I think it's really hard to try to understand what is going on here. And I think the key question that you asked is, do we encode this as a episodic disease with spontaneous improvement? Or is this a condition? that has been ameliorated by a treatment that we don't yet know. Um, and that's the part that I think I'm really, really interested in, because to invoke the possibility of GCA being so severe that it results in complete vision loss, and then to learn that it spontaneously improved without treatment, I think is almost incompatible with the diagnosis. And the same is true of, for example, just to reflect on the conditions of Tolosa Hunt, it is a condition that can definitely wax and wane, unlike GCA in its severity. Though in Tolosa Hunt, the complete loss of vision is a major red flag against the diagnosis, with the vast majority of patients having ophthalmoplegia alone. So I guess it goes to show you how you really, really need to know, did she get treatment or did she not? Um, and I think the accuracy of the cranial nerve 3 palsy is also really, really interesting. So what am I doing now? I think that I would probably recognize the difficulties in getting outside hospital records in real time, and would make every effort to understand, what is the syndrome before me right now? What is she here with now? And then, after confidently understanding what she is here with now, try to connect the dots with what happened to her before. But I think the key question is something you already outlined. Is this a spontaneously dynamic syndrome, or is the dynamism here as a result of the introduction of treatment? And that is going to be a profoundly important variable to help us understand what's going on here. All right, Artem, tell us a little bit more.
All right, great point. So some of the review of system points here. So she mentioned that she had some left temporal tenderness, some facial numbness on the left side, feeling overall congested in her nose, denied any eye redness or injected sclera, no jaw claudication, no ear pain, no rashes, and no symptoms in the right eye. So that's all I have here. And if you have any additional questions, I'm happy to answer, or we can just, go to other, past medical history.
Why don't we fill out that the rest of that medical history and maybe stop there? Yeah.
Sure. Past medical history, essential hypertension, dyslipidemia. It was reported that she had glaucoma as well, although she wasn't sure about it. And also mentioned that she had a rheumatoid arthritis. And there's just one line about rheumatoid arthritis. She was diagnosed 1 year prior to all this presentation. Was tried on biologics and was tried on etanercept, which she didn't tolerate, which is one of the TNF inhibitors. And then eventually she was placed on prednisone. And she has been on prednisone taper, and on admission, she was on prednisone 10 milligram a day. So she had some steroids on board.
Oh, I bet Kirtan, you're like rushing to discuss this. I love it. Maybe if we just divide our conversation, I'm curious what your thoughts were with the review of systems when you didn't have that medical history. What were you thinking then?
Yeah, so with the review of system, again, if we have left temporal tenderness, it does raise the question that is this actually coming from the temporal artery thickening or hardening, and which could again guide us towards the giant cell arteritis. And the facial numbness on the left side points to the fact that maybe it's the trigeminal nerve which is affected in some manner, which is why the patient is not able to feel. And the reason now it is important is because where does the trigeminal nerve travel to? Again, it turns out like everything regarding near to the cavernous sinus, and if there is a cavernous sinus pathology, that could explain the numbness as well. So further, our suspicion is more and more that pathology is at back of the eye as well. And I think no jaw claudication, that so jaw claudication is not very sensitive or specific. Some people can have jaw claudication because of TMJ disorder, and some people may not have jaw claudication even if they have fulminant GCA. So with that review of system, is hard to move towards one particular diagnosis, but certainly the suspicion of GCA goes higher. And that question, whether patient receives steroid or not, we got that question now, and looks like that despite being on steroid taper, the patient's symptoms are still present.
Superb, absolutely superb. Yeah, I think what's really interesting to layer onto your thinking is if you hear eye pain, 95% of eye pain is the result of involvement of the anterior structures in your schema, which almost always cause a red eye. There is profound diagnostic specificity in the combination of the patient saying, my eye hurts, but you not seeing the source of that pain. Most posterior eye diseases are painless. And the presence of pain in the posterior structure prioritizes three diagnoses. The first is retinal necrosis, which is a rare consequence, but has to be thought of in this patient because it's a rare consequence of varicella zoster virus. And so very close assessment for the possibility of a rash, and close ophthalmological assessment is going to be very important in this case in a patient who is immunosuppressed. So retinal necrosis from zoster is something that is a no misdiagnosis. The other is optic neuritis, which you discussed already, especially, and the third is GCA, vasculitic optic neuritis. So those are the three diagnoses that are commonly posterior and hurt. The vast majority of posterior is painless. And so here, when we see eye pain without eye redness, the probability of a sinister diagnosis is very, very high. I completely agree with you. What happened to your thinking when we got the medical history?
Right. So with a medical history, what I have learned over the years is that whenever in rheumatology you look at the medications, we often think that, well, steroids are there, it should take care of all the autoimmune conditions, but it's not as simple as that. Every disorder has their own particular biologics which works. So for example, in GCA, TNF alpha is not a good agent, and prednisone 10 milligrams is also not good enough. It might be good enough for something like polymyalgia rheumatica, but 10 milligrams is a very teeny tiny dose. You need like pulse dose methylprednisolone for such conditions. And when the RTEM said that patient was on biologics, what I was looking for, if the patient ever received tocilizumab, because if somebody received tocilizumab and if the patient had GCA, then it's very hard to believe that they didn't respond, because after steroids, tocilizumab has like the best efficacy data for GCA, and often people come out of CRAO if they get tocilizumab. So this patient never received tocilizumab, so that still makes me wonder that whether this patient still could have GCA or not. And with the history of rheumatoid arthritis, what I would like to clarify more is that it was diagnosed 1 year prior, but what's the state of rheumatoid arthritis? Like, is it like very active, not well controlled, or if it is well controlled? Now, as Rabih said, that there is no evidence of a scleral involvement as far as we know. Now, we will see in examination if the patient has redness or not, because RA most likely causes scleritis, and which can cause this pain. But again, RA is unlikely to explain the vision loss and everything we have discussed so far. But just to clarify, I would like to know that what was the state of RA.
Yeah, I completely agree with you. I think that whenever you're rendered and you're given that the patient has a diagnosis of rheumatoid arthritis, to recognize that the diagnostic error in the diagnosis of rheumatoid arthritis affects up to 20 to 30% of patients with RA. So at first glance, you should take that diagnosis and question it significantly. Most patients with rheumatoid arthritis present with a symmetric polyarthritis. And so at this stage, my mind is not locking into this diagnosis of RA, but rather assuming that this person had presented with a symmetric polyarthritis, which has a differential diagnosis. And hopefully this patient has RA. The confidence in RA will be increased by three things: her serology, her x-rays, and her response to treatment. And so for me, the RA is in red, both because it's a very interesting diagnosis in this patient, but also because it's a diagnosis that should be scrutinized with a red marker. And the three things that will be helpful are: what are the serological status? What is the X-ray status, and what is the response to treatment? But I think given the profound overlap between RA and vision issues, it's a very good idea to start to think, could this person have corneal involvement with RA, an especially devastating form of RA? Could this person have scleral involvement, which you're right is the most common? And then very rarely you can have posterior eye problems from RA. But I'm also wary of the possibility that an inflammatory condition with a prodrome of symmetric polyarthritis is now declaring itself in a more specific way in the eye, and this patient does not have RA at all, is a very important possibility. Um, but I think it's also really interesting, Kirtan, because I think your mind is locked in on excluding and thinking of GCA um, to share the notion that RA and GCA have a love relationship, um, and that even if this person doesn't have if this person does have RA, the subsequent diagnosis of GCA would not be coincidental alone and would be part of a relatively newly described but well thought out association between RA and GCA. So long story short, I think that the exam is going to be really, really key here. I'm glad your hypothesis that the patient got steroids is bore fruit. I'm really grateful for your teaching point about GCA needing a lot more than prednisone of 10 and TNF blockers. I'm really excited to see what the exam has. And are there any other thoughts, Kirtan, that you wanted to add before we hear from Artem?
No, I think this is perfect. We can get the examination.
Awesome. Alrighty, terrific.
Perfect. So I'm just going to add information about like other parts of history really quick. So family history, no history of premature cardiovascular disease, no history of cancer or autoimmune diseases. And for social history, she's a lifetime known smoker, denies using alcohol. She lives at home with her family, former office worker, no recent travels, no recent sick contacts, and no non-drug allergies. So now let's move to vitals and physical exam. Vitals, temperature 98.4, Fahrenheit, heart rate 72, blood pressure 142/78, respiratory rate 16, and oxygen saturation 98% on room air. Physical exam, so general, she's visibly uncomfortable, but not in respiratory distress. Here, head exam. So I put here like ophthalmology exam and neuro exam, so to be more detailed, specific. So her pupils, left pupil was minimally reactive and had normal intraocular pressure. Extraocular movements were restricted in all positions. And anterior and posterior eye segments showed normal findings, including optic nerve, macula, and vessels. So this is for left eye. Right eye was all normal. So cardiovascular exam, normal for the sake of time. So respiratory, normal as well. Abdomen, also normal. Neuro exam, so for cranial nerve 3, 4, and 6 on the left side, ophthalmoplegic. Cranial nerve 5 decreased in V1 distribution on the left side. Cranial nerve 7, left-sided facial droop. And cranial nerve 8, 9, 10, 11, 12 was normal. And peripheral upper and low extremity motor sensory function was also intact and normal deep tendon reflexes. Musculoskeletal exam, no joint swelling or tenderness, no palpable effusions, and skin, no rashes. So I think we can stop here.
Kirtan, this is like a massive. Where are you thinking now? Maybe let's
Right.
just focus on your interpretation of the neurologic exam first, and then we'll discuss
Sure. Right. And actually, Artem, I wanted to clarify one thing. You said that patient had left-sided facial droop as well.
Yes, this was on exam. That was noted.
Okay, perfect. So as we were discussing all through and through that what cranial nerves are involved is going to be key. And now we have evidence that patient has complete ophthalmoplegia, which happens when 3, 4, 6, all of them are involved. So we have 3 nerve involvement already. Then the patient has facial droop, which means the patient has 7th nerve involvement as well. V1 is involved as well. So now the question becomes that how can we localize the involvement of multiple cranial nerves? The pupillary examination is also important because we know that patient's pupil is not responding. So kind of like relative afferent pupillary defect. And important thing is that RAPD can be caused by anything which is obstructing the rays from reaching to the optic nerve. But Artem told us that the examination in the anterior and posterior aspect of the globe is clear. So it's not like we are dealing with some corneal or pathology in the lens. So the problem seems to be at the level of optic nerve itself, which is not able to relay the messages to the brain, or either the messages are not coming back because of the cranial nerve 3 involvement, which is like afferent and efferent pathway. So multiple cranial nerves are involved. Now our job becomes that how do we localize the pathology? We have done a lot of progress in reaching to this stage to localize the pathology. And now we can say for certain that something is wrong with the posterior aspect. Either it's in the cavernous sinus or in the orbit itself. So for the possible diagnosis, now I would consider GCA would become less likely in my mind just because of the fact that also, although it can affect multiple cranial nerves, but affecting cranial nerve 7 is like really, really rare. It can involve like cranial nerve 3, 4, and 6, but not cranial nerve 7. So we have to think beyond this now. And this is where I think the imaging will be really important to make sure there is not a mass lesion sitting there. So people can have, let's say, optic nerve glioma. Patients can have lymphoma. Patients can have sarcoma, metastatic lesions, anything which is obstructing multiple cranial nerves or infiltrating along the path of cranial nerves, that will be important. And now that we have complete ophthalmoplegia, my suspicion for all the diseases like sarcoidosis, IgG4 related disease, Toloshan syndrome, all of them are running high on my mind. Although other findings may not be compatible, but the examination is so profound. That's why I want to consider all those pathologies one by one. And one rare thing I would like to mention here at this point in time is that if somebody has all the features of GCA, like temporal artery tenderness, patient has vision loss, patient has relative afferent pupillary defect, but if you think it's not GCA, then what mimics the GCA very closely? So one entity is AL amyloidosis. So AL amyloidosis is known to infiltrate the blood vessels. It is known to infiltrate the optic nerves. It is known to infiltrate the optic pathway. And there have been numerous NEJM, CPSs, and review articles in past 3 years which have honed on this aspect that how AL amyloid can be very cryptic when it comes to infiltration of various neurovascular structures. So that is something which I will keep at back of my mind in case everything else turns out negative one after another. So priority is get the imaging study, make sure that everything is fine at the back of the eye.
Yeah, I completely agree with you. I think, Kirtan, if we review our cavernous sinus anatomy, we'll remember that there are three cranial nerves that go through there. It's 3, 4, and 6. And then there is most of 5. So 3, 4, and 6 go through the cavernous sinus. V1 and V2 go through the cavernous sinus, but V3 does not. An important omission in the cavernous sinus is the facial nerve. And a key question in this case will be, is the facial nerve involved in an upper motor neuron pattern or a lower motor neuron pattern? I.e., is there complete facial paralysis, or is there sparing of the upper half to help you localize the lesion to either central or peripheral? So Artem, do you know off the top of your head if the patient's lower motor neuron was more a pattern, or do you remember the pattern on exam?
Yeah, she didn't have a sparing. So this was like, entire.
Excellent. So this suggests that the localization here is very likely peripheral. The only place that is peripheral, that is the only place that causes a lower motor neuron facial palsy that is still central, is either the facial nucleus itself or in the subarachnoid space. A subarachnoid space or brainstem diseases are unlikely to remain strictly unilateral for this degree of time, meaning that if you have such profound effects on one side, you're likely going to get them on the other side. So I think now you know that all these cranial nerves are involved in the face and not in the brain. And the question is, how do you unite them? And at first glance, they're not easily unitable by an anatomical disease process because the facial nerve does not merge well with the cavernous sinus. So in my mind, there's two possibilities. This patient has a multifocal disease process that will show up on imaging in two different places, either invading the invading the cavernous sinus and invading the pathway of the facial nerve. Or this is a subradiological microscopic infiltrative disease process that will not be seen on radiology. So I'm not expecting the patient to have one abnormality. Either they will have two parts of the skull involved, or they will have none. And that inference is coming from the idea that the facial nerve does not course through the cavernous sinus. So the radiology here is either going to be super concerning or not helpful at all. It will likely not be subtle, simply from the wide localization that's present here. And I agree with you, Kirtan, that's the key next step. The most efficient pathway to solving this problem, in my opinion, right now, is to continue to be vigilant on the nature of the problem. What is it? What is it? What is it? What is it? And you can see how if we lock in our thinking and go down specific entities, how you can easily be thrown a curveball you weren't prepared for. You think about the story being GCA, 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 has a history of RA, not getting enough prednisone, has all these symptoms, and then boom, you get this exam. So my advice for all of you, keep all of your energy on trying to understand the nature of the problem before you start to figure out what is the solution. And the nature of the problem is only one of two possibilities. Either this is a multifocal radiographic disease process, or this is a subradiological disease process. A problem in the middle is unlikely to be the case, and that will help us make a lot of progress. All right, Artem, the mic to you, my friend.
Thank you. I just wanted to make like one correction. So social history is lifetime non-smoker. So she's not a non-smoker, but never smoked pretty much. So that.
Thank you. Wow, attention to detail there. Thank you, Artem, for paying attention to the board.
Okay, so for the we'll start with, I guess, some basic labs. As you know, they always get those labs. So CBC, I'll just give you like whether it's normal or abnormal. CBC was normal. CMP was also normal. And inflammatory markers, ESR, CRP, came also normal. And then we can give you some initial imaging that they had. So they did a chest X-ray, which was normal. EKG was normal. So now you want to get head imaging. So CT angio head and neck was done. And they said no angiographic abnormality, but the patient had enhancing soft tissue mass at the left orbital apex. And there was questionable remote lacuna infarct of the left lentiform nucleus. And also, CT angio of the neck showed that there was a right upper lobe mass with spiculated margins measuring 2.7 by 2.3 by 1.8 centimeters. So now I'm going to stop here.
Amazing, Kirtan. Thank you, Arthur. That was really, really helpful. I'm really curious, Kirtan, what did you think of the labs? How are they helpful to you in this case, you think?
Sure. So the labs are helpful in a way that we know that ESR has very high negative predictive value or highly sensitive in ruling out GCA. So that is one thing I'm taking this. And same for CRP as well, that if it was a fulminant rheumatologic diseases, like GPA and things like that, you would expect ESI and CRP to be on the higher side. So that is what I'm taking from the labs. And now regarding the examination, what do you think, Rabi? Should we comment on that or not yet?
Yeah, please go ahead.
Yeah. So on examination, as we were discussing in the previous aliquots, that we need imaging because there could be a mass sitting at the back of the eye, which is causing all of this. So now we do have a mass, but now the question becomes that how would we define the mass? Like, is this mass a malignancy? Is this mass a granulomatous tissue? Is this mass, if it's a malignancy, if it's a primary ocular stuff, or is it a metastasis from somewhere else? And that is where the lung imaging will be very important. Like the patient has this right upper lobe mass. Now, what we can do is that we can look at the prior imaging studies to make sure that this mass is not something new. And if this mass is indeed new, then we will, ask our radiology colleagues to help us like really delineate that what this mass looks like. Is this mass looks like a cavitary lung lesion, or is just a big nodule? Is it a solid component? Is it a liquid component? What is going on? Because if we say that this mass is, let's say, actually representative of a malignancy, then it would be like either adenocarcinoma, either it would be small cell lung cancer. Now, the patient is not a smoker, so you think more about adenocarcinoma and things like that. Now, metastasis to orbit is common, but metastasis just at the level of orbital apex is a little bit unusual, if not impossible. So that is one thing to keep in mind. The other possibility is that what if this mass actually represents the rheumatologic disease, which can affect the orbital apex as well as the lungs. So the two disorders to consider is one of them is GPA and another one of them is sarcoid. Now, the reason why I'm mentioning GPA is because in the review of system, RTEM told us that the patient had some sinus fullness or something. Now we know that this thing is way overcalled. People can have sinusitis for 100 different reasons and not due to GPA. And you should not say that, hey, this person has sinusitis, so it is GPA, but just how the flavor of the case is evolving. So I will keep that thing in my mind that if this upper lobe lesion, is it compatible with GPA-like lesions or is it not? And sarcoidosis as well. We know that sarcoidosis has predilection to affect the upper lobe. And we have talked about sarcoidosis before as well. It is one of those rare diseases which can affect the facial nerve, whereas like GPA, IgG4 tolerant are not very likely to cause facial nerve involvement. So the fact that sarcoid can cause that and now we have lung lesion, I would like to clarify with radiology that what's going on there.
Excellent, superb, absolutely superb. Kirtan's like feeling the heat now. We're making a lot of progress. If I were just to do the job of just like keeping track of things, to serve as your a secretary here, Kirtan, I agree with you. We have all the eye stuff explained by the mass, except the facial nerve. So this problem now becomes 65. And instead of all the stuff about the eye, we can just say orbital mass. But the facial nerve is separate. It doesn't collapse into the orbital mass. So 65, orbital mass, facial nerve, lung mass, and then relevant history, RA on etanercept and prednisone. And I think this whole case is basically 65, RA, etanercept, prednisone, lung mass, eye mass, facial nerve. And I just emphasize the facial nerve is not explained by an orbital apex mass. And that, as you said, was a very helpful clue to help you prioritize the DDX of orbital masses. So that explicit point, it needs to be made that it's completely separate. So how do you make progress here? I think the first thing that you said is not to say mass equals cancer. Mass can prioritizes cancer, but also can be compatible with autoimmune diseases, you said, and also infections. The infection category will probably grab most people's attention in a patient who is immunosuppressed. And that attention has to be given to tuberculosis and histoplasmosis. But the reason I think that you would probably, in a clinical reasoning exercise, not in real life, undervalue those things is you would expect some form of prominent inflammation in the CBC or the ESR or the CRP, some form of it. But I think in real life, you're like, wait, I have to make sure this is not an infection, especially an infection known to go to the brain and the eye. Are there cancers? Of course, could this be lung cancer going to the orbit? For sure. Could this be melanoma metastatic to the orbit and the lungs? Could this be breast cancer metastatic to the lungs and the orbit? Very, very possible. But I think that what is the authentic approach? I think the authentic approach is to realize that this patient is really not having much of an inflammatory response. And makes you wonder, is that a clue to the most gentle of these diseases? And the most gentle, I think, would be an autoimmune disease. Um, and I think if you had to then say, okay, this is a patient with an autoimmune disease, RA, presumably, getting another autoimmune disease, well, that's not unheard of. There are many connections between them. But you said it earlier, whenever you're thinking of an autoimmune disease resulting in autoimmune disease, the first thing you should think of is it a drug-induced autoimmunity? And why is that crossing my mind? I think you're making a very good case for sarcoid. You're saying this person has apical lung disease, a lung eye, and a cranial nerve 7 involvement, very evocative of sarcoid. The first question with sarcoid is, why is a 65-year-old woman getting sarcoid? On the upper age of the limit of sarcoid. And one very important possibility is this is drug-induced sarcoid from the etanercept. So I think in real life, the panic being caused by a TNF blocker unleashing infections is really, really the driver of it. But the nuance point that the drug might be unleashing autoimmunity in the form of TNF blockers induced sarcoidosis is really important consideration. But for me, Kirtan, I think this case is all about advanced anatomy knowledge. To not discard the profound clue that is that the patient has a separate problem, and that's the facial nerve that is not explained, and getting as much juice out of that clue will be very, very important. Any other thoughts come to your mind before we make progress?
No, Ravi, I agree with you that we have seen this multiple times that although TNF alpha inhibitors are used in treatment of certain complications of sarcoid, but they are also likely to cause it. In fact, this is more true for etanercept compared to infliximab and other monoclonal antibodies. This is decoy receptor. So you are right, I agree with that. And only other thing I would comment is that what's the next step? How would we make the progress? So biopsying the orbital apex is almost impossible. I mean, it will cause so much morbidity and mortality. So the ideal thing is, looks like this patient has right upper lobe mass, and we would like to see if it could be biopsied either through the EBUS or either through the peripheral percutaneous route. And that would give us a lot of information, because if it turns out malignancy, then we would think very hard about possibility of sarcoidosis. If it's indeed a malignancy, then as Rabih said, we would think that, well, what if the patient has multifocal processes going on, and orbital apex is one thing, but probably patient also has something in the salivary glands or like some metastasis there, which is obstructing the facial nerve, like just anatomically, gross anatomically, rather than at the microscopic level. So I think biopsying the lung mass is something that we could consider.
Excellent. All right, Artem, tell us more, please.
All right, there's a lot of brainstorming going on in the chat, so great points also. So additional imaging. So of course, the patient had MRI. MRI of brain with without contrast, as well as MRI of orbits. And I'll give you like only pertinent findings. So she was found to have ill-defined asymmetric enhancement related to the left orbital apex, left optic nerve sheath, and left cavernous sinus. And for the also the patient had MRI venography of the brain that showed normal venographic findings. And also the patient had CT chest with contrast, which showed right upper lobe spiculated mass that we already described, but no other masses in the lungs and no lymphadenopathy. So I guess the question, what would we do next from here?
What do you think, Kirtan? Has anything changed for you? Are you still interested in a biopsy, or?
Yeah, I mean, the thing is that because the fact that patient has like this mass-like enhancing lesion in the apex as well as cavernous sinus is again the same differences which we discussed earlier. Like sarcoid can do it, malignancy can do it, tolosartan can do it. The key is to figure out how to get to the diagnosis, because tissue is the issue now. Now, no matter how many serologists you get, nothing is going to help you. You need the tissue. And I think getting to the lung biopsy is essential. But I was curious, Abhi, that are we missing any other major differential diagnosis that we probably cannot get from biopsy?
I don't think so. I think that you might have more insight into the disease process and more clues if the ANCA serology is positive or if the vitamin D analysis is suggestive of a granulomatous disease. But I think microbiological assessment in this patient is often considered, say, depending on where she resides, a cocci or histo analysis. But I think whenever a disease is kind enough to coalesce into a specific mass, declaring itself in such a way to say, hello, pathologist, here I am. This is what I am. I think you should thank it for doing so and make the diagnostic pathway easily, recognizing that a biopsy may give you a good news and an answer, or it can give you bad news and no answer, or it can give you no news in that the sample was insufficient. So being prepared for a biopsy being diagnostic, uh, negative, or insufficient is also really important. But that would be my next step too. I'm curious. I would just say I don't know the answer of what the morbidity of an orbital apex biopsy is in a patient with complete vision loss. If vision was preserved, then I would be very worried. But I don't know how the ophthalmologist might be thinking, oh, the eye is not working. So is the morbidity lower? I don't know the answer to that. But I am gonna send an email to one of my friends just to ask them. All right, Artan, tell them more. Tell us more, please.
Of course, thank you. So while we get in all these results, we of course, as you may imagine, like a lot of specialties were involved. The patient was getting empiric antibiotics. ID was thinking, maybe it could be some fungal infection, as some of you already mentioned. But all this serologists for different fungi came back negative. Blood cultures came back negative. Even the patient had nasopharyngeal laryngoscopy done by ENT, had normal findings there. And I guess next step was to try to get the biopsy. So as you already mentioned, the patient actually had bronchoscopy with EBUS and had the lung mass biopsy done. At the same time, maybe like the following day, neurosurgery also got involved because, as Rabih mentioned, that they wanted to, the primary team wanted to see if this mass, first of all, if there's any therapeutic benefit of removing some of this mass, and also trying to get more tissue to see if those, things are related. So the patient eventually had biopsy of two sides, so lungs and brain. So, and anything you want to do, like since you had so many differential, diagnosis points, any additional labs you want to order? The patient also had lumbar puncture with normal studies, but any like blood serologists, any autoimmune studies you guys want to do while we're waiting for biopsy reports?
So I think biopsy is going to be key, but we can get ANCA just to be on the safe side. And if we are really thinking of amyloid, then probably SPEP and UPEP. But otherwise, I think biopsy is going to be key. Yeah.
Yeah, so ANCA was checked, ANCA panel with MPO, PR3, it came back normal. They even checked RF, CCP for rheumatoid, also came back normal. They checked ANA, came back normal. Complement levels were normal. ACE also came back normal. So everything so far has been normal. So now, and in the meantime, the patient was started on pulse dose steroids just to see what, if there's any response. So the biopsy results. So lung biopsy showed, let me show you. Yeah, so the lung biopsy showed areas of granulomas, necrotizing granuloma. And they did IgG4 staining, and IgG4 to IgG ratio was about 50%. And they also, for the periorbital mass, they showed the areas of inflammation and necrosis, and also with the increased IgG4 to IgG ratio. And the patient also had serum IgG4 levels checked, which was normal. So I guess, what do you think the diagnosis was? And this is not the end. I just want to, for the sake of time, to see your, some thoughts before I move.
Kirtan, do you think this is IgG4 disease? What do you think?
So now, this is again one of those, red herring or luring kind of thing. Whenever we hear the word IgG4, we get attracted to it, but you have to be, very careful about the pathology. So usually in ideal world, IgG4 related disease do not cause granulomas. Like it's not something which is baked in the pathology. And more you want is like something like obliterative phlebitis, which is not what we are hearing. And we don't even hear story from fibrosis. So that is one part I want to comment on, that although IgG4 related disease might be a possibility, we have considered that ahead of time, but I won't hang up on that. It could be sarcoid as well. Regarding the necrotizing and non-necrotizing part, I just want to clarify again and again, we have done this on VMR. There is no such thing that if it's non-necrotizing, it is sarcoid only, and if it is necrotizing, it is not sarcoid. Sarcoid can do whatever. There is in fact something known as NSG, like necrotizing sarcoid granulomatosis. So basically, necrosis doesn't help me a lot. Granulomas is something which I am thinking of more. Now, Tolosa Hunt is granulomatous disease, but it wouldn't affect the lungs.
Yeah.
So of all the possibilities we have discussed so far, still my mind is more on sarcoid. But of course, like infection, now I don't know if the culture will grow something, but it's just doesn't feel like that. Like how would TB cause facial nerve palsy, or like how would histo cause that? So it just doesn't feel right. It looks more like sarcoid, but of course, there could be something that I am missing.
Yeah, I agree with you. I think the cultures are going to be the most important investment, but recognizing that it would be a highly atypical presentation. I think that there are two words that you should be allergic to when you hear the diagnosis of IgG4 disease, which is granulomas, and then also necrosis. Necrosis is almost unheard of in patients with IgG4 disease. And while the IgG4 level is elevated in only 80% of patients in the serum, so the fact that it's normal doesn't exclude the diagnosis. But here, the diagnosis of IgG4 disease is unlikely to be fully explanatory in the absence of eosinophilia on the biopsy, in the absence of obliterative phlebitis, and in the absence of fibrosis, and the presence of granulomatous inflammation and the presence of necrosis are very, very unusual features. So for me, Kirtan, I'm stuck between sarcoidosis. It's not cancer because the granulomas would be unusual in solid cancers that we're entertaining. Either the infection will grow, in which case the epidemiology of this patient would have been a great clue. So the question is, what kind of autoimmune disease? And I'm stuck, honestly, between sarcoid and GPA. Why? RA has a relationship with GPA, very interesting one. But RA has a relationship with sarcoid through etanercept. The presence of necrosis is a very evocative word for GPA. And the question is, what about the negative ANCA? Well, yeah, 90% of patients with GPA with systemic involvement have a positive ANCA. The probability of a negative ANCA in GPA goes up the more restricted the disease is. And if I'm being authentic, I'd say sarcoid causing a right upper lobe mass versus GPA causing a right upper lobe mass, I'd probably lean a little bit more towards GPA. But the counter to GPA is the facial nerve palsy. But I think those are the two leading granulomatous autoimmune diseases. The more angry the disease is, the more it is GPA. The more gentle and sneaky, the more likely to do is to be sarcoid. So those are the two things I'm toggling with. I don't think I can distinguish, but how would you do it in real life? You need to look at the biopsy closely to see is there granulomas with vascular involvement, or is there absolutely no vasculitis on the biopsy? So that would be the key step. But I think an overlooked test is a UA. Is this person had 3+ proteinuria and a few reds on the UA? You'd be like, oh my God, this is totally GPA. So that's the tension that I'm having. I'm curious what you think about that tension, and then we'll pass the mic to Artem.
No, I agree with you, Rabih, that it's hard to commit to that. And although we know that P-ANCA is not as sensitive, but C-ANCA is like really, really sensitive. But when it comes to a disease which is just limited to ocular tissues, it may not be as sensitive. And as I just said, that NSG, like we have seen this case like just probably 1 month ago, that necrotizing sarcoid granulomatosis, it's like an overlap of sarcoid and GPA, like the weird combination. So of course, biopsy will be key. And last thing, again, this is to make sure we are covering our bases. So we discussed about infection, we discussed about autoimmune diseases. Now, regarding the malignancies, now we did discuss that how lymphoma can be sneaky, lymphoma can do anything. But again, the hard question, can it cause facial nerve palsy without evidence of any obstruction there? So that's the only part. So I think biopsy is going to be key. And I agree with you, Ravi, that sarcoid GPA, it's hard to say.
All right, Artem, what do you got? You guys really, really have
So
this case on the edge.
yeah, like a lot of good work in diagnosis here, I guess. The patient, as I mentioned, did get positive steroids, was transitioned to prednisone taper, and discharged recommended to follow up with the rheumatology, within 2 to 4 weeks. Unfortunately, the patient was lost to follow up, and then she was seen in the clinic 4 months later. At that time, she said she was feeling kind of weak. She was having some joint pain, and she also had some eye redness, and also she was seen by ENT because she noticed that she started having deformities of her nose, and ENT diagnosed her with the bilateral nasal valve collapse. So, and then, because she was so weak in the clinic, she was instructed to go to the emergency department to get, additional studies and get additional treatment. She gets to hospital, and then her repeat ANCA actually this time comes back positive. Both C-ANCA and PR3 came back positive. She was again pulsed, and she was given rituximab. So from this, I don't know if you want to reflect or you want me to say something. I don't know how you.
Just so happy that you brought this case, Artem, for many reasons. But I remember when Kirtan fooled me and presented a case of MDA5 dermatomyositis with initially negative MDA5. And so I'm so happy to see you bring a case with very similar features, going to show that serology is not a single test, that you can repeat it over and over again. But yeah, Kirtan, I'm curious what your reflections are, what you're thinking in this case, and what do you think are the rich learning points that you will take from it?
Yeah. So I think the fact that we did consider sinusitis as something, I'm happy about it. I didn't just show it, sinusitis there. So we thought about that. And I think the learning point is what Rabi said. Like that is something which I have told to Rabi again and again, that I personally strive to focus on the problems which are in perspective. So that is something which I often miss in real life, that there are so many things going on. You are excited, you are interested, but you lose the focus. So Rabi always teaches me that. That is what I appreciate the most, that the focus in this case was that how can we explain the facial nerve palsy and how it is separate from the orbital problem. And then once the lung mass came, how do we overlap the orbital pathways and the lung pathways? And eventually we honed in on two very crucial differences. Sarcoid and GPA, both of them can cause the same findings, but then the necrosis part was a little bit weird. And although the IgG4 is very highly positive in the biopsy staining, but you don't have the obliterative phlebitis. So that argues against that. So I think the attention to details is something which I will take away from this case. And I will echo this again, as I have always told before, that vasculitis is everything. Cannot be like I have to use this sentence now. This is the best thing that could happen, that I'm discussing my first case with Rabi and it's a vasculitis case. So I cannot be more grateful for that.
Kirtan, the whole time I felt like I was discussing with a colleague the whole time. And I think it's a testament to your tremendous skills. I think the lesson that I took from this case is to continue until the very end, not to think of individual diagnoses, but to try to get to the bottom of the problem. And when you start to see, when you can talk all you want about what it could be, but when you start to see this is a 65-year-old woman with a lung eye syndrome, really focuses the differential diagnosis. And then when you say a 65-year-old with lung eye syndrome characterized by necrotizing granulomatous inflammation, it's an easier problem to solve, much easier. So for all of you listening, I think watch as Kirtan shares his thinking about the possibilities, but at the same time shares how he's going to move the case forward. And ultimately, it cannot be ignored that this is a person with rheumatoid arthritis. And so I have been itching to show you this visual about the extra-articular manifestations of rheumatoid arthritis and to focus you on the vascular category and how RA can have its own vasculitis, but how it's very well described that patients either get a ANCA overlap vasculitis usually with features of GPA, and have an association with GCA. The two diagnoses that we were most worried about are not incidental diagnoses in a patient with RA. There is a really fascinating relationship in patients, especially in patients who get diagnosed with RA as older adults like this patient. So really, really interesting case. But we have a rheumatologist extraordinaire with us here, Artem. I'm really curious what teaching points you can emphasize for us and what you learned in this case.
Yeah, I really actually learned a lot just listening to what you guys said, and I like how when we started talking about rheumatoid arthritis, and Ravi, you mentioned that, you know, certain features that probably go against rheumatoid arthritis in this patient, And in general, I think for this particular patient, here having some inflammatory arthritis features initially that was thought to be rheumatoid arthritis, and later on she was seronegative. So in seronegative rheumatoid arthritis, I always question, whether or not it's a true diagnosis. And we see more and more patients that actually have something else. So also, I think her having GPA is probably she was serologically behind. She had pathologic findings that were consistent more with the GPA rather than IgG4 related disease. But of course, serologists, they can come later on positive, like in her case. And also what I found that, there are some cases where they talk about overlap of GPA, IgG4 related disease. But I think in this patient, it wasn't even overlap because she didn't have like storiform fibrosis, obliterative phlebitis, and PR3 antibodies. Like if you read about their like nature, those are also IgG and IgG4 antibodies in their nature. So there's a high percentage of patients, and I think somebody mentioned the chat as well, so that have GPA, and then if you do a biopsy and do IgG4 staining, they will have, high number of IgG4 positive cells, and this ratio can be also elevated. So I think that's something to keep in mind because this will affect the treatment, and this will, to me, like internist/rheumatologist, it affects prediction of possible complications. In patient with IgG4 related disease, I'm not going to be, expecting to have like diffuse alveolar hemorrhage in the future or, glomerulonephritis. But in the patient with vasculitis, there are so many different complications that can happen in the future that I need to be aware of.
Yeah. Amazing. There's so much wisdom and learning there. Thank you so much for sharing that. Uh, I'm really grateful to you, Artem, for I think there are very, very few fellows who have the time and bandwidth to join VMR. And I think this week has been VMR Fellows Week with Rob presenting 2 cases and showing up today, and Artem, you presenting this fascinating case. I think it's a very special kind of person and a special kind of physician who, as a very busy fellow, makes the time to join here. So thank you to you, and a big shout out to Rob for joining us. It's been a delight to have you. And a delight to share the stage with you 2 days in a row, Kirtan. I had a lot of fun. But I will now pass the mic to Napreet. Napreet, maybe just for the sake of time, this case is a very dense one. You can just share 2 or 3 of your favorite teaching points.
Thank you, Robbie, and thank you, Atam. It was such an interesting day. It was like sitting on a roller coaster, up and down, and with the teaching points of Kirtan. Uh, it was a really, really good case, and the teaching point, like which I'm taking away from this case, is more on the side of how to approach the patient, right? Like when Rabi in the beginning was telling us, like, because the patient had 3 complaints in the beginning, right? Patient had vision loss, ptosis, and pain in the left eye, and as Rabi said, what to prioritize, which symptom to prioritize first. So like we need to figure out the morbidity and diagnostic specifications that can help us. It can help us prioritize which condition to approach first. And then another teaching point that I learned was when Kirtan was telling us when we have a eye problem, always approach with the symptoms of the eye, whether it's a blurry vision or a complete vision, and always approach anatomically, like from the cornea to the end of the eye. That's how you should approach that thing. Another very important point that I get during this case was the Tolliser-Hunt syndrome. I never heard of this syndrome before. So as Keaton presented this thing, we learned it is a rare disorder that causes severe and unilateral headaches with orbital pain and with weakness of eye muscles. Another very important point that Robbie was telling us during this case was the patient for eye problem, 90% for any anterior eye problem, patient have red eye, and posterior eye pathology are always painless. So that would help us, that clinical finding can help us navigate where the pathology is. And as the case was going further, when we found out mass on the CT scan, Keaton was telling us to be very specific and go further down, whether it's a malignancy or it's a granuloma or it could be an infectious, and what kind of mass is it? It is a solid mass or a liquid mass. And another important point that I get through this case was antracept that can cause drug-induced sarcoidosis. So that can help us find to the diagnosis. Along with that, cutting short the conversation, that we can get ANCA negative, and it's always good to get a repeat ANCA. Along with that, if we have a RA and we are suspecting RA, always do serology and joint involvement. Those are the things that can help us get to the diagnosis, and those were few of the important teaching point that I got through this case.
Absolutely amazing recap. I love how you did it spontaneously off your cuff. That was so, so cool. And I agree, all those were really, really cool points. But at the end of the day, I think that point that Artem emphasized and that Kirtan taught us earlier is just because one test was one result before doesn't mean it doesn't change. And I think it was really, really cool to see that. All right, y'all. Happy Thursday. Happy Thursday. Oh my gosh. Still under the weather. Happy Saturday. Hope you have a wonderful rest of your day. And we'll see you next time. Bye.